Good afternoon, everyone. I am presenting a paper on adenovirus. Since recently, from last 2022 to early parts of 2023, the state of West Bengal witnessed a sudden surge of adenovirus cases, and there were increased morbidity and mortality. So we did one study to find the clinical profile and predictors of outcome of children with severe adenoviral pneumonia requiring PICU care in Tertiary Care Hospital of Eastern India. Myself, Vikas KV, a postgraduate trainee from NRS Medical College, my co-investigator being Dr. Arnab Bishwas, who is also a PICU in charge. Adenovirus has been increasingly found to be involved in sporadic cases and outbreaks of community-acquired pneumonia in infants and young children. Most of them have uneventful recovery without requiring any intensive management. In some patients, adenovirus infection causes severe pneumonia, disseminated disease, which may quickly lead to refractory respiratory failure, ARDS and MODS in varying combination. Without timely intervention, the mortality rate is as high as 50%. Unfortunately, no effective antivirals or vaccines are available presently for the prevention or treatment. So, supportive care along with timely management of complications and close monitoring remains the mainstay of management. The background being the state of West Bengal in India witnessed sudden surge of adenoviral pneumonia cases from late 2022 to early 2023 with increased morbidity and mortality. And this study was done to describe the one such outcome over a period of 5 months. My main objective of the study is to describe the clinical profile, laboratory parameters, treatment, and predictors of unfavorable outcome of critically ill children with severe adenoviral pneumonia infection. Study details. Basically, this study was done in PICU, our intensive care unit at NRS Medical College. The study population were mainly the severe adenoviral pneumonia cases which required PICU admission, and study period was from December 2023 to April 2023. And sample size were 24 children, and these were all positive for adenovirus in viral culture, and it was a basically prospective observational study, and consent and ethical and scientific clearance was taken accordingly. The inclusion criteria being all severe adenoviral pneumonia patients with age group of 1 month to 12 years. The exclusion criteria included the patients aged less than 1 month and above 12 years, children with known malignancies, COVID-19 positivity and HIV, and post-operative patients and requiring surgical intervention, and children who have left against medical advice. Basically, in our unit, all severe adenoviral pneumonia patients were given standard supportive care with moist O2 inhalation, and as per their requirement, high flow or non-invasive and invasive ventilation were given, and fluid management done as per standard protocol, and antibiotics was started whenever there was suspicion of secondary bacterial infection, and MODS and hyperinflammatory syndrome was managed with anti-inflammatory therapy, and mortality indicators were basically assessed by using PRISM and PSOFA score. The statistical analysis was basically done using SPS software. The chi-square test and Fisher-Exhaust test were used to test the association between the outcome and categorical variables. Basically, the p-value less than 5% was considered to be statistically significant. Some of the results we obtained were the majority of the population were mainly involving age less than 1 year, and the gender were predominantly of male population. The clinical features mainly being respiratory distress followed by fever. Since we being a referral tertiary care center, we had received almost a terminal ill patients. So we also found the number of patients with shock at almost 16 cases. And the complications involved were having respiratory failure and HLH, ARDS and myocarditis. And almost we had 3 cases of HLH and none of them survived. And ventilation, 10 patients required NAV ventilation and almost 14 patients required mechanical ventilation, and the prognosis was very bad in case of mechanical ventilation. And treatment here, we had given IVIG and steroids, and in some cases both a combination of IVIG and steroids. And here, when IVIG trial was given, the outcome was favorably better. 4 patients received IVIG and almost 4 of them have survived. And on results, the statistically significant p-value have been marked in red. Basically, age less than 1 year were significant, and at the time of presentation. The more the time of presentation, the more severe were the disease, and the prognosis was very bad. Then comorbidities. Comorbidities were statistically significant, like congenital heart disease, low birth weight, and preterm were the most to be affected. These are the clinical features, and except HLH, none of them were statistically significant. And these were the in treatment and outcome. We had analysis done, which showed again 10% of 10 people required NIV, 14 people required mechanical ventilation. And in lab parameters, the CRP, ferritin, and lactate were significant, statistically significant. In non-survivors, we had higher levels of CRP, higher levels of ferritin, and higher levels of lactate levels. And for mortality indicators, when we calculated PRISM and PSOFA score, PRISM score and PSOFA score were found to be statistically significant. Some of the in discussion part, basically adenovirus study in India, very hardly we have found only minimum of 10 studies. Of that, majority of the study have been done in other parts of the country. And in one such study, Zia Bang et al. Showed pediatric patients with longer duration of fever, hypercapnia, low serum albumin levels, invasive mechanical ventilation, and IV steroids are likely to develop poor prognosis. And Anil Rajbanshi et al. In this study found that males were predominantly affected, and 67% of patients presented after 1 week of appearance of symptoms. And in their study, HRCT done in recurrent symptoms had post-infective bronchiolitis obliterans. And Knox et al. In their study revealed children with severe adenoviral pneumonia had higher levels of AST, LDH, PC, and ferritin and D-dimer level. And A. Mujumdar, this study was done from NICET, ICMR, where they found that the recombinant human strain of adenovirus type B73 is most commonly the factor for causing increased mortality and morbidity in adenovirus cases. And adenovirus accounts for almost 5% to 11% of bronchitis, 2% to 10% of bronchiolitis, and 4% to 10% of pneumonia cases in infants and children. And conclusion, severe adenoviral pneumonia with unfavorable outcomes were predominantly infants, preterm, comorbid, fever, persistent respiratory distress, shock, raised inflammatory markers, lactate levels, PRISM, and means of scores. Survivor outcomes were better in those who received IVIG than who did not. Our observation may add some more positive lights on our existing language, and thus may improve the quality of management of severe adenoviral pneumonia in near future. And limitations were, since it is a single-centered small-scale study, we had very small sample size, and genotypic variants of adenovirus couldn't be extracted. And these were some of the references. Thank you.
Thank you, Vikas. And congratulations for presenting such a relevant and nice study. We all have gone through that period of adenovirus surge. So I have 1 or 2 questions. Number 1, what was the basis of diagnosis of adenovirus pneumonia? It was just a clinical diagnosis, syndrome-like, or it was lab-confirmed adenovirus? And if it was lab-confirmed, did you do typing of adenovirus?
Basically, the children presented to us with complaints of cough, cold, and fever clinically. Since there was a period of adenoviral surge, we had
so it was a clinical diagnosis. It was a clinical diagnosis, then it would have been named as adeno and adeno-like viruses, because adenoviruses cannot, whatever with the search, unless you prove it by lab, you cannot have. And then one more issue is bronchiolitis obliterans. One of the studies in discussion you have shown that they have you made any attempt to show how many of your children developed or were on the process of developing bronchiolitis obliterans?
Actually, we have none of the cases for follow-up. We have not, in our study methods, we have not taken the follow-up cases.
Okay.
Just to clarify Madam's point, I think you have taken only the patient who are confirmed
Confirmed adenovirus.
on
cases.
adenovirus.
Out
not
of
the
50.
He's saying, they haven't done any lab diagnosis.
Viral culture you have
Out of
mentioned.
viral culture,
It was viral culture or viral PCR?
mane PCR, the one we had.
So you
sent
have
for
mentioned viral
treatment.
culture. Okay. So he has taken only confirmed. Can you go back to slide please with the results? Next please. Yeah. So here we have taken 844 and 1281. So I don't know how does it mean, because when we take the cutoff 500. So 844, 1281. So what about 1000? So is there some linear relation and we have the cutoff, or it would have been better if you have taken the cutoff? Most of the criteria takes the 500. So then you have compared how many of the survivor had the less than 500, more than 500. Because for me practically it doesn't make much sense.
Actually, since our sample size was very low, we couldn't do multivariate regression analysis. So if that would have done, the cutoff would have been still more precise.
So did you try to analyze with the more than 500, less than 500?
Here, we found that the higher ferritin levels were having, higher lab parameters were having poor prognosis.
Okay, that's all right.
Thank you, Vikas. A good presentation. I would, can you show the slide with the IVIG, the number of patients who's received it, the treatment one. So you've also, my question is, you found that children who's received IVIG has got better outcomes, right? So how come some of them didn't receive it? What was your indication and why didn't all of them receive it? If you know that it's, they have better outcome.
Ma'am, the main for IVIG, the one is the access of treatment options and the cost availability. All the time, the availability is an issue. And moreover, in IVIG cases, we used in case of severe sepsis cases who are having a secondary bacterial infection. In case of steroids, where we had suspected cytokine storm and raised inflammatory marker levels, and those were the cases where a steroid trial was given.
So, madam asking, so did you have any number of patients in non-survivor group who met the criteria of receiving IVIG and did not get the IVIG?
Actually, we had 2 patients who received IVIG in non-survivor criteria who succumbed.
You have shown only 0. IVIG 0.
No, both IVIG and 0. That's both steroid.
No, IVIG group 4, 0, right? The third row.
That is without steroid, only IVIG.
You were saying non-survivors, amongst non-survivors, none of them received IVIG. Sir is asking that were there any patients in that group who were supposed to receive IVIG, but due to cost constraints or availability constraints, they could not receive IVIG. Were there patients, or how many of such patients were there?
Moreover, there were 4 such kind of patients who couldn't receive.
But you mentioned 0.
So there must be some patient in this group also who could not afford. Can you go back to previous slide? Because little confusing. The IVIG, the numbers are little confusing for me. Previous slide, the bar gram. Yeah, this one. So how many patients actually received IVIG?
4.
Only 4 patients?
4 patients received IVIG and 4 of them were survivors.
So out of these 4 patients, 3 also received steroids. You mean that?
No, this IVIG were the separate group and both this.
So out of these 3, it is 3, no? 3 and 2. So 3 out of the 4 of the first group, 3 were out of the 4 of first group. Do you mean that?
I mean here I am considering IVIG as a separate entity, one part of treatment, and the both group includes both.
So total patients who received IVIG were 4 plus 3, 7 or only 4?
7.
Then that's all right. Because if you look at the IVIG alone group is 4, and the mixed group is. Both is, what is 2, what is 3, mixed group is 5. But none of the non-survivors got the IVIG, right?
Yes, sir.
So how come a non-survivor has the 3? So, anyway, thank you. That's all from my side.
Thank you so much. Thank you.
Very energetically presented the papers, and thank you, they have
Thank
done
you.
well.
Thank you
And
very
thanks
much.
to
Thank you, ma'am.
organizers, though I'm not very much into critical care, thanks to the team, especially Mihir, for making me a part of this conference. Thank you.
Thank you very much, ma'am. Thank you. Thank you, judges and the presenters. So we move on to our next session.